So typically in the Health Coalition, we think of Medicare in Canada and in Ontario as perhaps the largest and best achievement of equality in Canada by working people. And in today's society, with increasing inequality, that is standing out as a more and more odd and peculiar thing, and which will become more odd and peculiar. I was slightly confounded by the question because we were asked to talk about ideas to increase equality. And in fact, when I review the struggles that we've gone through for the last 10 or 15 years, all of those struggles have been about fighting attempts to decrease equality, the equality that we had achieved in the years before. That is unfortunately a reality, but I will try to add something that will move towards that while still cognizant of the fact that we are in a profoundly defensive struggle at the moment to save Medicare. We are in a very major funding crunch for a number of reasons: aging, population growth, increased utilization, changes in the technology. There is very significant funding pressures on health care. The Auditor General reviewed these, the Ontario Auditor General reviewed these, and his estimation, based upon radicals such as the Toronto Dominion Bank and others, was a 6 to 7% cost pressure per year to keep up with those things. The Auditor General, before the election, looked at those at what that would mean if the government did stick to its funding promise of 3.6% funding increase annually for healthcare. His conclusion was that this would mean, on top of a 2-year wage freeze, it would mean for various sectors, and I'll mention just one, hospitals. This would require $1 billion in savings over 2 years, $1 billion in savings in order to provide a comparable level of service. Unfortunately, after the election, as these things often happen, the promise vanished. Drummond and his commission came up and proposed 2.5% funding increase for health care. The actual funding, as proposed now, is just slightly under 2% funding for health care. So with that, the deficits that our various healthcare providers are facing are significantly increased, and the reduction in services that we're going to be experiencing is going to be increasing. This is a significant change in healthcare. There has been tightenings for some time, but this is an utterly different situation than what we faced in recent years. Indeed, I should note that compared to the first term of the Harris government, this is much worse. Harris actually increased health care funding, and it was a notorious issue during his regime. He increased health care funding 4.1% per year. That was at a time when inflation was less than it was, at least until this past month. So we are in a rather different world. Of course, in Harris's second term, he had actually changed course on health care, quietly changed course on health care, and his funding increases were much more significant than the 4.1% he introduced in the second term. People will pay for health care. Even with all the advertising and crap we get thrown at us, people can still ferret out the idea that health care is worth paying for, and they will pay for it if they have the money. The only question is, will it be for everybody, or will it just be for the few? That is the question that we are actually debating when we talk about the health care funding and the crunch that we're facing. Ontario, contrary to what you might think, is actually a very low funder of health care, 8th out of 10. We're well below the median of all the provinces. Also contrary to Drummond's mythologizing, where he said we were going to go up to 70% of healthcare spending of the provincial budget on healthcare. Spending on healthcare as a percentage of the provincial government has actually declined since 2002. Ontario is actually also a low spender compared to other provinces in terms of government spending, and the lowest program spending. The major way in which, from our view, that is what has happened is that it's not healthcare that's eating up the budget, it's tax cuts that are eating up the provincial budget, which I think are, if you can read it, is sort of set out in those charts. The major way in which Ontario has become the lowest cost provider of healthcare in Canada, or very much below the medium, is through hospitals. The hospitals in Ontario are the most efficient across the country, significantly cheaper on a per capita basis than anywhere else. And this has to do with a number of features of healthcare in Ontario. Canada has, I should say, the second fewest hospital inpatients in the 34 nations of the OECD. Well, it's accepted that if you want to get into a hospital, as I've had some people come very recently trying to get into a hospital and being evicted because you can't get that care. The only country that we do beat among the 34 rich nations is Mexico, which you might debate whether Mexico is a rich nation, but anyway, that is the only nation with less. In terms of discharges per 100 population, Canada is about half the OECD level. Ontario is much lower than other provinces. Very significant decline, 33% decline in the last 15 years in terms of hospitalizations. We are now probably have set a world record for developed nations. We now have, just this past year, it was just announced, we now have lower than 7,000 hospitalizations per 100,000 population. The per capita rate is now 6,958 per 100,000 population, a 1.3% decline from the previous year. Likely that is the lowest of any developed nation in the world. We're kind of an outlier in terms of our hospital capacity. And this is reflected in a number of different ways that we have. We have astronomically high bed occupancy levels, very much connected to hospital-acquired infections, the superbug infections that we see. We have in Britain, they complain about hospital bed rates which are over 82% as being dangerous and leading to superbug infections. Ours in Ontario are about 98%. This is a complete non-issue, unfortunately, in the debate in Ontario, or has just become a bit of an issue lately, but it needs to be more of an issue. Very dangerous for this. And what is beginning to happen is the backups, that backup from in the hospital, ultimately backing up into the emergency rooms. People can't get into the emergency rooms, out of the emergency rooms, and ultimately the ambulances begin circling the hospitals, waiting to discharge the patients into the care of the hospital. And we're beginning now to get a situation known as code zeros, or sometimes code reds, where there are 0 ambulances available for 911 calls in a certain area because they're at the hospitals waiting to discharge their patients to a hospital emergency room that can't take it because they can't discharge their patients into any beds because the beds don't exist, and that essentially means the staff don't exist to provide that care. There's 2 areas in healthcare in Canada where there is very significant and very strong coverage that's protected by the Canada Health Act for healthcare: doctors, services, physician services, and hospital services. Other services have much less public coverage for them, and it's much more dodgy. Sometimes you get coverage, sometimes you don't. Much higher private payment for those services. So the attack on hospital services means essentially an attack on what we've achieved collectively as citizens, because that's where we're guaranteed the care. We haven't been able to achieve that level of guarantee in other sectors, and that is certainly a battle that is needed. But unfortunately, we don't have the puff to get there quite at this time. But the other aspect of it is that lower income people tend to use hospital services more than upper income people. That's another reality about where the care is. People won't have doctors. They get care in the emergency room. They don't have the supports that can allow them to have care in the home if they are susceptible to that. So that's a key aspect of what is happening. How are we for time? A couple more minutes? Okay. So hospital spending is declining as a share of hospital spending. Hospital funding is the second lowest in Canada. We've lost 18,500 beds over the last 20 years. We've lost 30,000 hospital beds over the last 30 years. Fewest beds per capita of any province. But here's the other irony. Home care is repeatedly thrown at us as a solution. Indeed, it needs to be strengthened and developed. But it's kind of like pointing, there's this whole raging problem out there in terms of amount of care, and there's this one little problem, one problem down here, and saying that you can solve the problem just by dealing with that one issue. But here's the double irony on this, is that home care funding, despite all the focus and talk for about 30 years about that this is the way to solve the problem, has actually decreased as a percentage of health care funding. Very shocking, and it surprised me when I saw it, but actually true. Rationing of long-term care, very significant issue. The government has also quietly not only decided to squeeze the hospital side, but to squeeze the long-term care side. So there is now a radical increase in the wait times that you have. Less than majority get their first choice of a long-term care bed. That's got a major impact on families. But I also just want to touch upon this question of home care and increased resources, because that is part of what we're told is happening, and it is the justification for the hospital long-term care squeeze. But home health care has actually been cut in recent years. That is contrary to what you might glean if you read the media releases from the government. But what has actually been increased is not the nursing, the occupational therapy, the physiotherapy, and those other healthcare services. It's the other very vital but much less costly home support services provided by personal support workers or lesser trained professionals. So that has increased, but in fact the rate of increase is decreasing. So even as we go into this new regime of dramatically lower funding for healthcare, the actual increase in the one area that's supposed to be the bulwark of reform is actually slowing down. It's slowing down by about 35%. So unfortunately, access to healthcare is getting worse. That is not sustainable. Rich people will not put up with it. They will not put up with the sort of care that you get in many of the hospitals. That politically, it's just not gonna wash. We need to increase that equality in order for this to be a viable future. Funding is far below cost pressure. So the first thing, and it reflects our report that John asked me to talk about, was do no harm. That's the first goal that we would ask, is do no more harm. We'd also ask that that there is very significant tax loopholes to the employer health tax. The first $400,000 of revenue, for example, is excluded from the employer health tax, supposedly designed to let small businesses off the hook, but in fact, large businesses get the same benefit just as much. And it could lead to a very significant increase in revenue. The other point that I'd like to make, and I guess I just missed the slide on this one, is that the first aspect of attainment of health, more important, I believe, than even smoking, is your socioeconomic status. So that is the first step towards the attainment of health, is to improve economic equality as a key part. So with that.